the risks are pretty low, but they're not zero. There's a 1% chance of, so when you go to do this thyroid surgery, the gland is really pretty superficial. So you've got your skin, and then there's some sub-Q fat, and then there's these long, skinny muscles we call strap muscles that sit there, but they're not a very thick muscle. And then you just kind of peel those apart because there's a little gap in the center of them. You kind of pull them like drapes, and then the gland's there. So it's not a very deep surgery. So it's not a very painful thing. You don't really, even though you move your neck, you don't move your neck so much with those strap muscles. Those strap muscles are for a different function. So the surgery isn't very painful. There aren't a lot of risks, but when you get in there, there is 2 little nerves that come up. They're called your recurrent laryngeal nerves. And even though they start up at your brainstem, they're part of your vagus. So the 10th cranial nerve comes down, and it comes down out of the skull base, down into your neck, and then it loops back up. And so that's why we call it recurrent, because it goes down and comes back up. And when it comes back up, it goes up into the thyroid, or underneath the thyroid, and it runs your vocal cords. So when we breathe in, we open our vocal cords, and we breathe in, and when we talk, we close them, or have them close together so they can vibrate and make the sounds we make when we talk. And those nerves do that. They do the opening and closing of those vocal cords. So we have to be very careful. And really, the whole surgery is about the recurrent laryngeal nerve. So one of the risks or complications of thyroid surgery is that you could have injury to your recurrent laryngeal nerve. And most of the time, it's just from us like peeling the gland off of it, and so usually there's full recovery. But if someone did have just some minor injury to their recurrent laryngeal nerve, they would wake up a bit hoarse because one of their cords might not be moving as well, so they might sound kind of raspy where some air is escaping from them while they're talking. If like in one of those Graves' disease thyroids, or if you had a really giant thyroid, or there's a really complicated thyroid that you were doing, it's possible that you could have both of your recurrent laryngeal nerves injured, and that's really terrible. When your recurrent laryngeal nerves do not work, luckily it doesn't leave your cords in a closed position, but it doesn't leave them in an open position either. It leaves them in this like middle position. We call it a paramedian position. So if you're just at rest and if you're talking, you actually do okay with bilateral vocal cord paralysis, but you go to try to do something, exercise at all, even just walk across the room, and your cords are not going to open fully for you to get a big deep breath in, so you're kind of always a little teeny bit short of breath. Thank goodness I haven't had any bilateral vocal cord paralyses. They really shouldn't happen. It should be a very, very complicated surgery. It should be maybe a recurrent disease or something really not normal to have both of them injured. So usually we just find those recurrent laryngeal nerves. They're usually pretty easy to find. And then we use a monitor. So we put, when someone's going under anesthesia for that surgery, they put a tube in for them to breathe, and we put sort of a special tube in that has electrodes on it to pick up any movement of the vocal cord. So when we find that nerve and we see it, then we can touch it with a little it's like a little stimulator, and you hit it, and then you'll hear a beep on the monitor, and so oh, that's it. It's not the vessel that's nearby or whatever, that's for sure the nerve, and then you kind of just know exactly where it is, and then peel the gland away from it. So we've got those monitors that help us find it, and they are pretty reliably located, and so we don't usually have problems with that. And then the second thing that can happen in thyroid surgery that we don't like to happen is that your parathyroid glands sit nearby. So your gland sort of sits in the middle of your neck, and then it has, we call them poles, but it's got this it shoots up a little bit up on the side and down, and up at the upper pole and the lower pole, there are these glands called your parathyroid glands. And they are totally separate from the thyroid. They do totally different stuff, but they can get their blood supply from the thyroid. So the vessels that can come into the gland, and then this other little gland sitting over here, and it has to come through this gland to get there. And so if you take this gland out, you can decrease the blood supply or completely remove it. And then sometimes they're kind of on or stuck to the thyroid gland, and so the thyroid gland is kind of a bumpy thing, and so you may think that's just another little bump of the gland, and remove a parathyroid gland when you remove your thyroid. And so sometimes they get removed inadvertently, sometimes they lose their blood supply. Luckily you have 4 of them, some people have 6 of them, where they might have a couple down in their chest, and then you're really safe because you really only need 1. So we're careful, but it's not like we have a monitor for those. So we kind of make some judgment. We know there's a space where they should be. They're not as reliable as the nerve, but again, we have more chances because there's 4 of them, and you really just need 1 of them. I've had people where they're all intact, where you left all of the parathyroid glands in there, and even confirm them, because we can take a little teeny piece of it off. If we think that's the para, we can take a little piece, send it to the pathologist and say, hey, is it? And then they come back and they'll say, yeah. So you'll know that you left whatever you left. And then sometimes they'll still have their calcium drop afterwards. So those parathyroid glands keep your blood calcium normal. And we don't really think about our blood calcium, but it's really everything. Every muscle in your body moves with calcium movement, movement of calcium ions, including your heart. And so after thyroid surgery, even if everyone thinks the parathyroids are fine, we always check the calcium. So right as soon as they hit the recovery room, we check a calcium, and then about 4 to 6 hours later, we check another one. Usually if the parathyroids are all damaged, like none of them are working right after surgery, then you'll see a dip in the calcium. Even when you've just closed up and gone to the recovery room, you'll already see a dip. And then if that's the case, we just keep them on calcium. And we keep them on calcium for 2-3 weeks, let those glands rebound. So it's not something that is a long-term problem, but you've got to be watching it afterward. So there are some surgeons that do their thyroid surgeries and let people go home, but they really shouldn't let them go home right away. They should at least get that first calcium, maybe even the second one, 4 hours later, and then if they just maybe left them on calcium, then they could let them go home safely. But so the main things are vocal cord movement and calcium management, and those are the main risks of the surgery, and they're both really, really uncommon to have any problem with them. And then, of course, there's having an incision in your neck. And most of the time, we hide it. So we all have little lines in our neck, and we try to find a line that's in a good spot, and we make our incision in that line. And we try to follow the curve of that line. So, I try not to make my thyroid incisions perfectly straight, try to put them in a line. And most people, they heal up well.